We're set, Chris? Well, hello, everybody. Welcome to the American Palliative Rehabilitation Alliance webinar. We are so very excited to have you here tonight and to have this mass of people that really care about the intersection between rehabilitation and palliative care. Before we get started with our speaker, I'd like to introduce myself and the co-founder of the APRA. My name is Ann Henshaw. I'm an occupational therapist. I work in acute care at Georgetown University Medical Center, and I teach at GW in the OTD program. My experience with palliative rehabilitation is both personal and professional, and I think that that the work we do is critical, and working together. Whenever we work together and we are on the same page as providers and have the same messaging, and when we collaborate, we provide better care to our patients and to our very vulnerable patients. So I appreciate you being here. I'm going to have my co-founder, Chris, introduce himself and our amazing students who have designed this website.
Hi, everyone. Thank you all so much for being here. This is really exciting. This is our second webinar. Our first webinar is posted on the events page of our lovely website. So I am a physical therapist. I'm a associate professor at Oakland University, and I practice clinically at Corewell Health. I'm also the incoming president of the Academy of Oncologic Physical Therapy for the American Physical Therapy Association. We also have Alicia Nacarado and Jordan Humitz, who are our graduate assistants, who are kind of our experts behind the scenes. They have really kind of been the inspiration for the website. So, you know, if you get a chance, take a look at the website, but what we are looking for is more content. So if you have a favorite article, if you have a favorite presentation, resources, webinars that you hear about, let us know, and we will be glad to post them and share them. Right now, I think we have excitingly over 130 people signed up for this alliance, and we'll be kind of sending you, you know, webinars. We're going to have another webinar that we'll talk about after Dr. Jessick's presentation, which is our next webinar coming up in a few months, and we'll probably be planning on doing something like this every couple of months or so. So I'm going to go ahead and stop sharing my screen and hand it back to Ann, and she'll introduce our esteemed speaker.
Thank you, Chris. It is my pleasure to introduce Dr. Tim Jessick. Tim is the Chief Medical Officer of Post-Acute Care at the Sisters of St. Mary in Wisconsin, and the co-founder and past president of the PC Now, the Palliative Care Network of Wisconsin. Tim is board certified in both family medicine and palliative care, and he spent the last several years teaching primary palliative care to clinicians and developing system change to improve care, and specifically to focus on patient-centered care. Tim believes that patient care is fragmented and provided in silos, and that communication is a skill that has not been taught well to physicians or any providers. He envisions a focused educational program that encourages provider communication and standardized documentation that ultimately results in reduced readmissions and reduced hospital mortality and reduced length of stay and better quality care for our patients. In Tim's own words, and I'll let you hear from him in a second, but this was my favorite, when providers in the system meet patients and families where they are, rather than forcing them to be where we are, then we're providing patient-centered care. So quoting you, Tim, on that note, I'm going to hand it over to you, and I thank you for your time tonight. I thank you for your leadership in this and for being part of our growing organization. Tim.
Well, thank you, Ann. That was very kind of you. And thank you, Chris. And thank you all for joining on Monday evening of all nights. This is wonderful. And what a great group. APRA really is. This is what a great night. I can't get over that. This is meant to really be a dialogue, right? I'm hoping to ask some questions. I want to learn from you all, because there's a lot for me to learn yet. And I'm really looking forward to what we can do even after this talk over the next couple of weeks, months, years. So for tonight, to start off with, I have a thank you, I have an apology, and I have a confession, right? Sounds like a bad joke, right? A thank you, an apology, and a confession. the first thank you is to thank you all. The work you all do is really, really amazing. To truly be patient and family centered, to spend the time with patients and families as you do, is a thankless job. At least I don't see a lot of thanks. I thank you all, but I don't know if you get enough thanks. I know patients and families appreciate you. I don't know if systems appreciate you as much as they should and as you deserve. So I do want to say thank you all, not only for tonight, but just for all that you do. It's super, super important. The apology really comes from me not knowing what I don't know. No, I do appreciate what you do. I do have a pretty good understanding of what you do, but I really underestimated this type of collaboration. And it wasn't until recently, and honestly, until this group came together, that it really opened my eyes what you all bring to the table when it comes to palliative care, when it comes to goals of care, when it comes to hospice care. And I have a lot of really good friends that are therapists that kind of remind me, but I didn't think about how big this could be until just recently. So that's an apology on my side. The second apology is I don't have a lot of slides for you tonight. So if you're expecting 121 slides to go over and memorize, I don't have those. So apologies for that. If you all have watched TED Talks before, well, this is a Tim talk, for whatever that means. And the third piece is really a confession, right? Right. I mentioned that what you all do is really near and dear to my heart. So near and dear to my heart that way back when I was in high school and I was trying to figure out what I wanted to do when I grew up, I wanted to become a physical therapist. That's what I wanted to do. So I went to my local hospital, physical therapy facility, and shadowed Pete Repke for years, hundreds of hours, just shadowing him, figuring out what to do and what this therapy thing is all about. Well, that's what I want to do. That's what I'm going to do for the rest of my life. Went to college. This is my goal. This is what I'm going to do. I even took a 5-credit biology course a second time to try to improve my grades. So it was really, really good. I didn't get in. I couldn't get into physical therapy school. At the time, they went by your science GPA, and I missed it by 11/100ths of a point. So I didn't get in. I'm not still bitter about the 11/100ths of a point, but I still remember that. So what do normal people do when they can't get into physical therapy? The thing that they want to do? Well, they go to medical school. Obviously, that's just the next best thing. So what's that? So that's kind of how this all started, but that's really where my mindset was to begin with. So just a little story about myself and kind of where we got to where we are tonight. I went to medical school, became a family physician, small rural area, right? So I did a little bit of everything, which in hindsight was fantastic. To be able to deliver babies and take care of people in the clinic and see folks in the emergency department and in the hospital, follow them in the nursing home, follow them into hospice as needed. Continuity wise, patient and family centered care wise, I learned so much. I just learned from so many folks. But I found myself always gravitating towards hospice and end of life care and having conversations because not a lot of folks were having these conversations. So I did family medicine for 12 years or so, did a lot of hospice stuff on the side, and then found myself doing more and more of these conversations, and actually started an outpatient palliative program before I knew what a palliative program was. And then it kind of got to the point where I decided I think I want to do this palliative thing. So did a year-long palliative fellowship, learned tons during my palliative fellowship, and thought, cool, I'll become a palliative doc. That's what I'm going to do. For the rest of my life, I'm going to have these conversations, and I loved it. I love meeting with patients and families, trying to figure out what siloed healthcare is all about and how we can help them out. But it always bothered me that even though I could have a goals of care discussion, even though I could help symptoms for a patient in one room, there are patients on either side that weren't having the same conversations. And that's with all due respect to my colleagues and the other professionals out there. Those conversations just weren't happening. Well, again, I'm happy that we could have that conversation, have that moment with our patients and families, but that didn't happen all over the place. So that really started the journey with, how could we train non-palliative specialists, non-hospice specialists, how to have these conversations? How can we get them to become more patient and family centered, right? You all by nature are very patient and family centered. That's just who you are, what you do. Nurses are very patient and family centered. Docs, not so much. We just aren't. That's not something that we were trained to do, honestly. So we started training folks. We started having courses for docs, for APPs, for nurses, for other folks, teaching them the words to, how do you have a goals of care discussion? What does that look like? What words should we use and not use? And that really started this journey of, how can we really help as many folks as possible, right? How can we train as many non-specialists as possible? So I mentioned goals of care a couple of times. That probably could be a bingo contest tonight. How many times is Tim going to say goals of care, and at some point someone's going to yell bingo because I said it the fifth time. Look, so if folks can hop in the chat for a moment, when I mention goals of care, what does that mean to you? Goals of care discussions. What does that mean to you when I say those words? What do you think about?
What's important to them?
Yeah, what's important to whom? To the patient. Yeah. What's important to the
Yes.
family members? You bet, right? Telling people they are dying. Yeah, that has to be a big part of this, right? What are their goals and what can we do for them? What is meaningful to the patient? Wow. Novel concept for a lot of healthcare folks. What's meaningful to the patient versus what's meaningful to all of us, right? Finding out what the patient and the family's perspectives of their current situation. If a patient thinks that they just have a little skin sore, but in fact they have terrible cancer, we're on a different wavelength, different phase where we are, where they are, right? So understanding what they understand is super important. Patient and family quality of life, meaningful participation, you bet. What do they understand about their disease process? That's just so key. We get on patients and their families all the time. Well, they just don't get it. They just don't understand. Well, maybe it's that we don't understand. Maybe we didn't ask the right questions. Maybe it's no one really communicated to them what was important to them based on what the disease process was, right? So it's super, super important. Living full life as capacities are diminishing, you bet. And this is where you all come in, right? What does living their best life with decreased function, with decreased time really look like? That's fantastic. Thank you. I want to talk a little bit about patient-centered care, right? So a couple of you already mentioned this and mentioned it really well, how, what is the patient's perception? What is the family's perception? That means we need to be patient-centered, right? We need to meet patients and families where they are. What is their understanding of the disease process? What are their goals, right? And then what do our treatment options which of our treatments make sense for them based on those goals, right? If we're saying that, well, you have to go to a nursing home, but they don't want to go to a nursing home, what do you all do, right? You figure out what you can do and how you can help them out best, short of going to a nursing home. So that patient-centered approach, that care approach is really, really crucial. I think I'm sure I'm preaching to the choir as far as that goes. So, this is where I think you all and what you do is so, so important, and why therapy and therapists and the work you do really aligns with patient-centered care very well, really aligns with palliative care and goals of care really well. When I do a palliative consult in the hospital specifically, and after doing thousands of these, kind of have a routine, right? I don't know what I don't know. I can read the chart, I can look at labs, I can look at x-rays, I can see what providers have said. What's super important for me is to go to the oncologist and say, tell me a little bit more about this patient's cancer, what's possible and what's not possible. To go to the social worker and say, can you kind of inform me a little bit about the patient's living situation or family situation? What do I need to know? What's possible, what's not possible? To talk to the bedside nurse. How has Mrs. Smith been doing today? Did she eat? Right? She didn't eat yesterday. Did she eat today? How's her confusion? Right? as often as I could, which is almost every single time, I'd reach out to the therapy teams, right? I would read your notes. I don't usually get a whole lot of information from your notes, to be honest with you. So I talked to them, and wow, the information was just so robust. Well, how's Mrs. Smith doing? Well, she's doing all right. Well, how's she doing ambulatory wise? They keep saying that she keeps saying she wants to go home. Is that possible? Right? How far did she go today? Well, she went 50 yards yesterday. She went 75 yards today, and she did really, really well, and really with one person assist. It was remarkable. Oh, or do we have to plan for equipment in the home? What other things do I need to know about? Oh, I think she'll just do just fine with a cane. I don't think she's going to need a walker or anything else. So what you all bring and the information you have for us is really, really important. One question, which is probably not a fair question for my therapy colleagues, is this patient, they want to send this patient in the nursing home. The people here don't trust her at home. Is she rehabable? Right? And with all due respect, do you all in your expertise think that this patient is going to get better and stronger? Right? Not that you all have a crystal ball, but I usually get a pretty good answer from you all, right? Yeah, I think she can get a little bit better, but I think there's a limit. I think there's a ceiling for her, right? I just don't know how much stronger she's going to get. I don't know how independent she's going to be. Well, we don't know that until we ask you all, right? And that piece is just so important. When I mentioned doing my fellowship, Anne mentioned we need to know the prognosis of these disease process to help make that decision. You bet. And part of this, and we'll talk about that in just a second, part of this is, what is the prognosis medical condition wise? Well, what is the prognosis with stage 4 non-small cell lung cancer with metastatic disease to the brain and the liver? What is the time frame there, right? Well, we might know from a condition perspective. I'm as interested in what you all think from a functional perspective, right? Just as important, and probably more important. We'll talk about that more in a little bit. So not only have I noticed and learned so much and benefited so much from what therapists have helped me with, functionally wise, what folks can and can't do. I remember distinctly in fellowship working with a music therapist. Just an amazing experience. We had a young woman, probably more in the teenage age range. She was blind. She was deaf. Had a hard time interacting with us all, but she had a incurable terminal disease process. We're trying to reach her, and we just couldn't. Music therapist came in with her guitar, started playing music. Boy, this patient could just feel the vibrations. She put her hand on the guitar, could feel the vibrations. You could just see the smile on her face. It was amazing. But then she get a little shorter breath and she get anxious. So what the music therapists do, start strumming, playing music, but start changing the cadence, a little bit slower rhythm to the music she was playing. So the patient could feel this, but at the same time, her breathing started to slow down. Basically matched what the music therapist was doing with the guitar. It was just amazing. Something that I couldn't have done with Ativan or morphine or anything like that. It was just remarkable. So I still remember that. The other big piece I think you all have is time, right? You will spend a lot of time with our patients, and you spend a lot of time overtime, day after day or week after week. So you get to see them. You get to see a picture of them initially of how they were doing and how they progressed or not progressed. What a gift, right? Unlike some of us docs that, spend a whole 2 minutes and 36 seconds, in and out, right? You all get to know these folks. You get to learn their names, their pets' names, their family names. What a gift. And the information you can gather is just incredible for us. We need to learn from that. We kind of talked about prognosis, time-wise, right? Time is a big part of prognosis. The second as important piece is function, right? Boy, I can't put my finger on it, but I don't think this patient is doing well. Well, you all can probably tell us what's going on. Well, they're not doing well because they're getting weaker. They're not doing well because they keep falling and they don't bounce back. They're not doing well because they've lost 10 pounds and their PO intake has gone down dramatically, right? That functional piece is as important as anything. So if folks go and say, well, we need to defer to the medical team for prognosis, I would say we need their help. We need your all help too, right? It needs to be a team approach, integrated approach. And this is where I would really challenge you all to speak up, right? If you're seeing this decline, if you're hearing decline from the patient, that's hugely important. Lisa said it's an absolute time of gift with our patients. And in my past, we are one of the first members of the team to recognize and address patients are declining and may not want to continue. Absolutely. Now, you bring this up with a provider, and they might say, well, wait a minute, their creatinine is just fine. Their x-ray looks just about the same. I think they're doing fine. This is where you can jump in and say, hey, I've been spending time with Mr. Smith. He's not doing well. He is declining. And oh, by the way, I've been listening to him. I heard him say he doesn't want to do this stuff anymore. He's getting tired. His goals are to spend time at home, focus time at home, right? Again, I would challenge you all when you're seeing this, when you're hearing this, number one, make sure you share that with the team. But number two, ask some more questions. Well, tell me more about you're tired of this. What does that mean? Right? And this is where you get to ask them these fantastic questions. Tell me more about what you're thinking or what you're doing. Boy, we just talked about a lot over the last half hour while we've been walking down the hall. With all this going on, what are you hoping for? What a great question. If this is somebody that just had a massive stroke and they're saying, well, I'm hoping to play tennis next week. In our minds, we're saying, oh, darn, where's that Jessick guy to have a conversation because he doesn't get it? The key is to kind of read in between the lines. Do we really think that they don't get that they may not be playing tennis next week? Probably not. But if our initial question is, what are you hoping for? And they say, I'm hoping to play tennis next week. Our response, your response really could be, boy, I wish you could be playing tennis next week after this massive stroke. What else are you hoping for? You will always get an answer. And usually an answer that's going to surprise you because all of a sudden, instead of I want to play tennis next week, it's, boy, if I could somehow live independently in the next 6 months, I'd be really pleased. What I really wish for is I don't have to be a burden to my family. Can you help me so I'm not a burden to my family? Yep, we can help you with that. We can definitely do those type of things, right? So that hope question and the wish statement is super, super powerful. But again, this is where, from a functional decline perspective, you see what's going on, and I think that is much of a predictor as anything else that's out there. Looking at your wonderful website, a couple of quotes popped out at me. One was more of a definition of palliative rehabilitation. Palliative rehabilitation focuses on the functional capability, again, functional capability of an individual and maximizes a person's potential to function and engage in community activities, even when living with a terminal illness. How empowering is that? That's huge. When folks are in their last weeks, months, years of life, there's not much we can fix. There's not much we can cure. But to offer hope like that, that's fantastic. The other quote I liked was, it supports the adaptation of ADL to maintain the best independence physically with emotional and social backing to lead a high quality of life while respecting their wishes. Wow. That could be the mantra for all of us, not just your group. It could be the mantra for docs and nurses too, right? That's just wonderful. So part of some work we're doing is trying to identify high-risk patients, because the care for high-risk patients might be different. How do you all recognize patients that are at higher risk? So higher risk of readmission, higher risk of death, higher risk of falls. How do you do that? What tools do you use? What do you look for? What tells you this patient is not doing well or may not do well?
Tim, I'll just jump in. we have a lot of, assessments, right? Formalized, standardized assessments. So we can certainly do those and test at the beginning, middle, and end. But I would say more importantly, it's the stuff that you were talking about, right? Like the things somebody said, ejection fractures, O2 needs, dysphagia, for sure.
Yep.
But sometimes it's that person telling you, I'm tired, I'm
Yeah.
done, this is hard. How much, how much more can I do or whatever, and listening to those cues and maybe, and that's what I love about some of the stuff you're doing is giving me some words to use in those situations, like the what are you hoping for, or the that kind of stuff.
Thank you. That's spot on. Some of the other comments, of course, ejection fraction being down, dysphagia, cognition impairments, perspective, judgment, pain. Those are changes that we say, hey, what's going on? Some of those maybe we can fix. If they just broke a hip, maybe we can fix the pain. Maybe there's something else going on. Assessing their cognition, their insight, their depression. Wow, if we have a patient that's really, really depressed, it's going to be really hard for them to get much better physically or mentally, right? Noticing the way they move, listening to how they repeat themselves. So again, function and physical piece, but also mentation, right? If someone's really becoming more and more delirious, if someone's becoming more and more confused, it's going to be difficult for them to cooperate with therapy, right? Physical therapy, occupational therapy. It's going to be difficult for them to eat and eat safely, right? So again, another big concern, one big thing to watch. And, as Ann mentioned, how can we look at data and numbers and things, but also keep our ears open to be aware to the words that folks say. Now, sometimes you might need to look into it further. Well, I just want to die. I'm tired of this. I just want to die. Well, tell me more about that. Are you really ready to die? Well, not really. I don't want to die, but my pain is so bad. I just can't live like this anymore. Oh, well, if we could help your pain a little bit more, would you want to live? Oh, heck yeah. Oh, okay. Well, I'm glad I asked. You're not ready for hospice. You just need better pain control, right? The work we're doing is looking specifically at identifying high-risk patients. And we're doing it a couple different ways. There's not one way to do this, right? I like the KISS method. I like the easy method. So we're looking at, we have EPIC at SSM Health. So we're looking at the end-of-life score, right, which is an EPIC score that looks at folks that are at high risk of dying in the next 12 months. But we're also looking at the readmission score. The readmission score is a nice objective data point that tells us which folks are at high risk of readmission. Now, when I was at Theta Care in the past, we used the LACE Plus score. It was a great functional assessment of a patient that tells us when folks really are declining and doing worse. Again, the idea of having some sort of objective medicine-y measure, right? It's good for those medical folks because they see this number. They can see this thing in EPIC that can tell us that, hey, this person isn't doing well. That can collaborate and that can coincide very, very well with our gut saying, I don't think this patient is going to do well overall. So I mentioned this project that we're working on now. We started at 2 other institutions in the past, and now we're doing it at SSM Health. And it's we're looking for high-risk patients that are coming into the hospitals, into the clinics, into the emergency department, or even at home. We're using end-of-life score and we're using readmission score. Again, you can pick whatever scores you want to use. The next piece is really, really important. What do we do with somebody that's high risk, right? Well, let me ask you all first. You gave some great examples of how to recognize someone's that's high risk readmission, high risk of dying. What do you do next? What do you do next once you identify someone that's higher risk? Get a palliative care consult. Well, yeah, that's good. Job security for us, that's fantastic. Do you all ever have conversations or further conversations? Yeah, I see some heads nodding. So this is where to pursue that a little bit more, right? If you feel like someone's declining, they're talking about declining, it's a great time to start asking questions. Tell me more about how you probably do this in your initial assessment, but what did you look like 6 months ago? How far were you walking last Christmas, right? What about 3 months ago? How far were you walking? What is it? What is your expectation? What is it that you want to do? Right. Consult and have a conversation. Good. Do both. Right. And then look for directives. Right. It's always important to see where advanced directives are if there's some direction that way. It's fantastic. Thank you for that. So the work we're doing at SSM Health is identifying high-risk patients, suggesting to the medical team that this patient needs a goals of care discussion, right? And to use the goals of care template to document those discussions. So within the goals of care template, this is for hospitalists, intensivists, surgeons, oncologists, cardiologists, primary care. I want them to address 3 different things. What are the patient's goals? A discussion of prognosis, not only time, but function. And the third is, what is the plan if there's future deterioration? Because patients in the hospital after a heart attack and chest pain, if they have this again in the home, what are we going to do? Does the patient want to come back to the hospital? We have a elderly patient with really advanced dementia. They're falling a lot. They're not swallowing well. They have aspiration pneumonia for the 2nd time because they're not swallowing well. Would any of us be surprised if they fall more, aspirate again? Probably not. Did we have that conversation with the family? Probably should. We're not wishing further aspiration pneumonia. We're not wishing further falls on this patient or family. But to suggest that other patients with really advanced dementia sometimes fall and have more swallowing problems over time, it's a fair statement. It's a fair discussion to have, right? That's prognosis. Right? You don't have to be an expert at everything, but say this is what might happen. Family, I think, would find some benefit in that. I keep thinking about exploration and expression of identity, how they can adapt meaningful roles. Absolutely. How can the patient express identity? What's important to them is how I'm reading that. You bet. So identifying high-risk patients, encouraging goals of care discussions, documenting goals of care discussions within our electronic medical record using the goals of care template, and then measuring it, having that accountability piece. So I was just meeting with our chief nursing officer this morning, and the question came up, well, if a nurse is having a goals of care discussion, where do they document this and how do they document it? So the goals of care template we developed for hospitalists may not work so well for nurses and for therapists and social workers. We need to have a good goals of care template for them as well. So if you all have one that's beyond kind of the typical range of motion and things, and this is how far they walked, I'd love to see it. So please email that to us so we can see that. But my hope is that we all document these discussions. At least in Epic, there's a section called an ACP notes section where all these discussions can occur. That can be the one source of truth where all goals of care discussions go. So heaven forbid this patient comes back to the emergency department. They have a starting point as far as what was discussed, what the patient said. If they said, I don't want to come back to the hospital anymore, then they don't have to come back to the hospital anymore. Or at least we start the discussion there, okay? So, I mentioned, starting to have some of these goals of care discussions. A couple of phrases, a couple of questions I think really, really work. I already mentioned the what are you hoping for? To have a question of what's your understanding of your disease process? I took a look at your chart, and I know you've been talking to a lot of providers. What's your understanding? What have you been told so far? Just kind of curious what you heard. If this is a patient with class 4 heart failure with an ejection fraction of 10 or 15%, and they said, yeah, I just have puffy legs. When I eat too many pickles, I get puffy legs. So no one's talked to you about class 4 heart failure with a bad ejection fraction of your heart? Not that I remember. Now, this is with all due respect to our colleagues. I assume good intent. I assume these conversations occurred. Sometimes patients' families just don't hear it, or they need to be told again, or it needs to be discussed further, right? So again, I assume that these conversations have occurred, but we won't know what has occurred, or more importantly, what the patient and family know, unless we say, what is your understanding of your disease process, right? So I think that's super, super important. The other question I pose or have you think about is when you're thinking about time, and you say, wait a minute, Tim, I'm not a pulmonologist. I don't know how long someone has with severe COPD. The question I ask others all the time and get immediate response to is, would you be surprised if they die in the next year? if in your mind you're thinking prognosis in time and trying to help come up with a treatment plan for a patient and family, either if you can answer that question or if you can't, to ask the attending, to ask the hospitalist, to ask the primary care provider, hey, I'm just kind of curious where we are with this patient. Would you be surprised if this patient died in the next year? I guarantee you'll get an answer almost immediately. You'll either be, no, I won't be surprised at all if they die in the next year. Oh, okay, so their time is limited. Or I would be surprised. I think they're going to do just fine. This new chemo is really good chemo. I think it's going to help. Oh, they just had this LVAD procedure done. They're going to do remarkably well with their heart failure. Thank goodness we did this procedure. Oh, okay, that might change how we do things, right? So when I think about what we all can do moving forward, right? We really do need your help. And as I mentioned, we're doing communication training for providers. We've done this training with over 500 providers to date. We need to train about 1,400 or so at SSM Health. That's provider training. We want to look at what we need to do for home care nurse training, social work training, care manager training, liaison training, therapist training, right? Again, you all do this, but what would communication training for you all look like? I don't know. I mean, I have an idea, right? When we do this training for providers, it's a 5-hour course. It's really in depth, right? It's a couple hours of didactic work, and this is the reason why we do this, and how can you be more patient-centered like the therapists are? Was that smooth? Was that I just kind of slid that in here. But how can they be more patient and family-centered? What does that look like, right? And then the second half of the 5-hour course is all simulation training. All right, we're going to practice having a goals of care discussion. This is the case, go. You're on the hot seat, right? I would think a similar format for therapists would work pretty well too, right? Similar words, different scenarios, but I think that would be really, really important. And the other simulation training I'd love to do with you all at some point is, you listen to a patient, see that they're declining, see they're high risk, hear with your own ears and see with your own eyes that, yeah, they are declining. Boy, they're really weak. I just don't know if they're going to get much stronger. And I'm hearing them say things like, I don't know how much more time I have. To work on scripting, how you bring this up to the attending, how you bring this up to the oncologist so you don't get your heads chewed off, I think would be really, really important. And if you all have scripting or do this really, really well, that'd be awesome. We'd love to learn from you all, right? I just want to set you all up for success, and more importantly, set our patients and family up, set them up for success so we can advocate for them. So I'd love to explore that further to see where we are and where we can go. So again, this is all about advocating for our patients. It's not about us. It's not about you. It's not trying to put a cardiologist in their place. It's advocating for the patients and their family members, right? Speaking up for them. To help minimize or reduce suffering, it would be huge, right? We put patients through way too much. If we can minimize that, reduce that, that'd be great. And if we can help them so they're not so scared. The unknown is so scary. If they know they're declining, if they know they're doing worse, but no one's talking to them about that and what that means to them and for them, it's hugely scary. Plus, they don't have a chance to talk about things. Try painting pictures. I'm sure you do that very, very well already. How were they doing before they came into the hospital? How are they doing now? What do we think they're going to be doing down the road? To be able to paint those pictures and share those with us. Hey, this is where I think this patient can go. This is where I think their ceiling is. But I think they're going to really, really struggle, right? Paint those pictures, share those with us. It will be super important. Read between the lines. The patient that just had hip surgery and has been falling a lot and has lost 15 pounds, who says, I want to be able to go back, live independently again, right? Read between the lines. What does that mean? Do they really not get this? Or are they just scared, right? And then when you see and hear these emotions, which happen, I'm sure you see it and hear them, right? Especially you start having these discussions, name the emotion. Wow, you seem really sad. Wow, you seem angry. Can you tell me more about that? Right? They're probably not mad at us. They're probably not mad at you. They're probably mad they're losing function. They're probably mad that they're pooping their pants and don't have independence and are embarrassed by what's going on, right? So name the nurse, the emotion, try to understand where that's coming from. Be curious. If someone makes a comment, boy, if I could, I just assume stay at home and not come back to the hospital again. This is 3 times in 3 months. I just want to do that. Well, I'm sure you're busy. I'm sure you have other patients to see. To be curious and say, well, tell me more about that. What does that mean to you? What would you do if you start getting short of breath again? Does anyone talk to you about that? Ask those questions. Explore that a little bit more. Be curious with them. So again, you all have been doing this work. You all are probably saying, Tim, welcome to the party. We've been doing this for years. It's nice that you finally woke up and appreciated us even more. I've always appreciated you. I underappreciated what we can all do truly as an interdisciplinary team. And you all do this better than we do. You already have your own tribe, right? You have your own interdisciplinary team and you talk all the time. We could learn so much from that. How do we help you all to speak up more? How do we help you all to have more of these conversations since you spend so much time with patients and families, right? Share that with us. So it's truly an interdisciplinary team type of an approach. Last couple comments. Number one is, I'm Ann might have mentioned this, but I'm also co-founder of a group called the Palliative Care Network of Wisconsin. Cool not-for-profit group. We have all these great tidbits, which are really more medically based. How do you treat hiccups? How do you have a goals of care discussion? How do you convert fentanyl to morphine? We don't have a lot of this stuff. We have one fast fact that is music therapy based. I would love for folks to submit a piece because these are evidence-based, peer-reviewed tidbits of information. What do folks need to know about palliative physical therapy? What does that look like? What can it do for patients? It's not all or nothing. Well, are we going full speed ahead or hospice? Because hospice clearly will never do therapy. Well, that's not true. This is how palliative physical therapy can help. This is how palliative occupational therapy can help. This is where the speech therapist could really step in and help with swallowing issues and not push a feeding tube, right? So to submit a fast fact would be wonderful. So please reach out if you're interested in doing that. Again, thank you all for joining tonight. This has been fantastic. Goals of care, you're doing all the time. Keep working on that. Focus on the high-risk patients. Start having some of these conversations or more of these conversations. Document these conversations. Share your lessons learned with the team, right? Keep advocating for our patients. I really do want to thank APRA. It's a great group. I'm happy to have joined and be a part of that. And thank you, Chris and Ann, for putting this all together. And I'll pause there and see if there's any questions.
Perfect. Thanks, Tim. Thank you so much for your wonderful presentation. Before we open it up for any other questions, I did want to share my screen just for a quick second to talk about next month's or next presentation here. So hopefully you can see, set your calendar for December 5th. It will be in the evening, probably at 8 o'clock. Check back on our website for more information, including a Zoom link. But Carlos Alanis is going to be presenting. He's from a health system in California that's escaping me at the moment. But he's going to be speaking on rehab therapies at end of life and really what we need to be doing for meeting CMS's hospice conditions of participation. So we will open it up for any questions in the chat, or if someone does have a question that they want to verbalize, just raise your hand and we'll give you permission to unmute. We're trying to kind of keep everything contained in case there were some people who didn't want to play nice when it came to Zoom bombing us and things like that. So we're being a little bit extra cautious. I was in another presentation last week that got Zoom bombed pretty harshly, so we're being a little paranoid about that. So any questions, comments, thoughts, or anything
There's a
else?
couple of thoughts in the chat. I'd say less questions and more. I think Lavanya is talking about communication and training is the missing point in physical therapy. I would say the same for occupational therapy. Just some of those words you use Tim, are not common for some of us. And so just using that, I'm wondering and I'm worried and what are you hoping for and what are you wishing for? Putting that into your back pocket so that you can use that easily, I think is important. Let's see. Trying to get team members to put themselves in the bed. Lisa, I agree 100%. I always say every minute I spend on the other side of the bed with family members who are sick informs me and makes me a better therapist when I'm on that side of the bed. Rebecca talks about bringing OT training with the focus on meaningful engagement and roles. 100%. Task analysis. Tim, I don't even know if you know that's a part of occupational therapy. Like we'll look at a task that a patient wants to do and break it down in a way that, is simpler for them. And that's sort of our training, and it's our core so that the person can do something that's really meaningful to them in a way that's somehow adapted.
That's fantastic. And again, what are lessons learned from that? I would think, number one, patients are, the fact that this is so person-centered for them is huge. Sometimes you can't achieve those tasks, I'm sure, but I'm sure you learn a lot about their will and how much energy and oomph they have and dedication they have by working on those projects, right?
Yes, 100%. I mean, that's, if it's you want your dog on your lap, we're going to build something for your dog to get on your lap, whatever the task. It's never, OTs can be very creative.
So let me ask the group, some of you have good phrases or words or thought processes when you do want to talk to the attending or primary care? They're wanting, they're kind of going with usual care, let's get them to the nursing home and just move forward. If you're hearing that the patients aren't wanting that or declining or don't want to come back to the hospital, do some of you have some phrases, or have you had some success talking to attending saying, this direction we're going is not really the direction the patient wants to go. We might want to rethink this. Anybody do this and do this well?
Tim, I won't say that I do it well, but really, when I do have those conversations with the physicians, I really talk about the facts, really what I saw, what I hear, and then really kind of just like you said, align it back to the goals of care. And a lot of these folks are pre-palliative care conversations, and my nudging is without saying it, blurting it out, because as you said, kind of that, don't you think this patient needs a palliative care consult? Is a good way to kind of break down relationships with your physician colleagues. So, I do kind of propose like, has anyone had a good goals of care discussion with the patient, or X, Y, and Z is happening and it doesn't seem to be in alignment with their goals of care. What do you think is usually kind of how I would approach it. So.
Great. Thank you.
So
I just, from the provider's perspective, and I know you'll all get this, the stressors they're on are huge. They're especially in the hospital setting, they're being judged and measured on, we got to get these patients out of the hospital, or hospital length of stay is too long. Well, guess what? You rush them out of the hospital and they get readmitted and they get dinged for that, right? So I can't underemphasize how tough it is for those folks and for the C-suite folks. So the more that you can meet that provider where they are. What are their concerns? What are they wanting you to do? Where are they coming from? How can we help them out, right? The better is for them because we're satisfying their need, but also helping the patient and the family. We can advocate for them. So this is where you could bring up, well, we got to get this patient out by noon, by noon today, right? Well, boy, Dr. Hospice, I know that. I know the pressures on you must be huge. I'm really worried about Mary, and she had a really, really tough morning. My fear is that if we send her home today yet, she'll be right back in the emergency department tonight. She's going to fall. And we don't want that for the patient or family by any means. And boy, we don't want that for readmission numbers. What we're suggesting is if we could spend one more day, boy, we'll see her twice yet today to work on some things. We'll have a better idea tomorrow. Touch base in the morning, but tomorrow I think might be more reasonable, right? You're representing the patient, representing the family, sharing your expertise, coming up with a solution from the hospital team, right? May not be exactly what they want, but they'll hear that, they'll resonate. First and foremost, patient safety and patient care. Number two, oh, by the way, you're going to get dinged for this because I think they're going to come back, right? Denise mentioned she works at SSM Hospital as well. Yay. How do we all make palliative care a priority in the hospital when there's such a push for discharge? That's such a great question. And I think it kind of goes back to the last statement, right? They're pushing for discharge and for good reasons. But if we can, number one, meet, well, two things. One is I'm convinced now, although from a job security perspective, yes, we should push palliative care for all patients. We need better communication training, and we need better education what palliative is and what hospice is, right? Boy, I've been banging my head for 12 years, and it's getting better, but it's still difficult. I'm convinced, instead of telling folks this patient needs hospice, this patient needs palliative, this patient needs the nursing home, where we always get these reactions. Whoa, whoa, whoa. Palliative, that means hospice, so therefore we shouldn't do this. Whoa, whoa, whoa. You're not sending me to a sniff. I know what a sniff is, right? We get these reactions all the time. If instead we meet patients and families where they are, figure out what's important to them, what they want, where they want to go, what they want to do. If they start saying, well, I think I want to be able to go home and stay at home. I keep coming back to the hospital, I keep falling. I don't know what to do. Well, what I hear from you is you want to be independent, you want to get stronger and stay at home as long as possible. Boy, I wonder if we could do more intensive physical therapy. We can't do that anymore in the hospital, but if we could spend time with you every single day, work on this hard over the next couple of weeks, boy, I really think we can get you strong enough, show you how to use that walker, get those quad muscles better, where I think once you do go home, you could stay at home. Are you open to maybe going to a facility where you could really do this therapy to that degree, right? I'm sure you're always having these conversations, but it's a little bit different approach of rehab is an answer to an issue that I have and that'll help me out. Or, oh, I want to stay at home. I want to be comfortable. I don't want to have my breathing problems anymore. I'm tired of getting poked and prodded. If somehow you had some sort of a program that helped me stay in the home so I don't ever have to go to the hospital, that'd be awesome. Hey, we do. We have this wonderful hospice team that can help serve you in the home, and they can do all those things for you. Oh, well, that's not what I was thinking hospice was. That's why I didn't want it before. Now I do, because it's going to help me out. Okay, now I want it. Does that make sense? It's a different approach in how we discuss this. But it starts with being patient and family-centered, meeting them where they are, echoing back the things we heard from them, and then suggesting that rehab, hospice, a palliative consult really might help them out, and really might help our providers out too, right? So it's a long-winded answer as far as the palliative piece, but to suggest that, boy, I'm really uncertain as far as the patient's goals. The patient's really confused about what's going on. They're kind of angry. They're kind of angry right now. Do you think we could have a goals of care discussion with this patient? Dr. Hospitalist, do you want to do this? Or oncologist, do you want to do it? And if they do, awesome. If they don't or they can't, oh, well, I wonder if we have a specialty team that could do that for us. Well, I guess maybe we should get palliative involved. Okay, cool. We can do that. Right? Different approach. Good. It's also helping us to understand that palliative is not hospice. Absolutely. But that's going to take some time. And again, if folks have preconceived notions about what hospice is, what palliative is, what nursing homes are, that's tough.
But I worry, Tim, when we tell them about hospice, that they think that it is a more hands-on, that there's actually, we're sending people out to help, because we're not, right? We're sending them home with a different group of providers, and their family is going to do most of the work. So I sometimes have to have conversations around what that looks like, so that they understand that their mom or whoever needs to still transfer them from bed to chair. A hospice person's not going to be there to do that.
Absolutely. And same thing for someone that's not on hospice. Okay, if you want to go home instead of the nursing home, this is what's going to be required. So painting that picture, what hour to hour, day to day is going to look like. Absolutely. There is one other comment from Rebecca. I think of this as I think of this as developing a culture of the doc having a checklist of referrals, rehab, palliative, social work, etc. Having a checklist of referrals. Rebecca, can you comment more on that?
You're muted, Rebecca.
Okay, I was trying to unmute. Yeah, I think part of it is the doctors have so much on their plate, so many things they have to keep track of. But if there's like the checklist of, hey, rehab is really something available. So hopefully in that hospital system, there is a place to refer. Palliative care, again, a lot of our hospitals don't have palliative care, but it helps the doc to know, hey, I've got social work, I've got palliative care, I've got rehab. They cover some of these bases that in a perfect world I could, but I can't. So if it's in art, kind of already in their mind of almost every patient I'm going to do this referral for, the exception is this patient doesn't really need palliative, or this patient really doesn't need the rehab. Right. But it's almost an automatic. And I think part of that is educating the docs that it's available, who we are, what we bring to the table, and how we're going to help that patient live their best life. Right. And hopefully they run into them outside the grocery store instead of in, room 1125.
Absolutely. Great points. And I think this is where you can toot your own horns a little bit. If you can follow up with the provider and said, hey, thank you so much for thinking about putting this referral in for social work, for physical therapy, for a palliative. Thank you so much, number one, for doing this. Boy, your patient's so happy with you that you did that. This is what we discussed. This is what we did. And this is what's going to help this patient out. You're passively educating them about what you do. You're thanking them for the referral and thinking about the patient, which we are thankful for that, right? And they might kind of learn that way what we all do and how we all do things, and get a pat on the back at the same time. So maybe it's a win-win-win. So I know we're at time. Thank you all so very much. This is a great evening. Hopefully we could do it again. Please send us emails, not only to the Alliance, but to me if you have questions, comments, or whatever next steps. But thank you all for the great evening.
Can we provide your email, Tim, to our group? Super. Chris, do you want to close it up?
Or yeah, it might be easier, Tim, if you have it by a computer, if you want to type it in the chat.
I will. I'll do that.
Okay, perfect. Thank you guys so much, and thank you, Tim, for your great presentation. You can see why we invited him, because he really does kind of get the big picture and really does see us as an alliance. And really conversations with him really even got Ann and I to kind of think about this as an organization. So, we are realizing that we're better together and we're stronger together. So thank you so much for the great presentation. If you know any colleagues who could not make it tonight, we will be posting this on our website. So the recording will be there probably in a couple of days. So that way you can watch it again if you want to, take some notes down. So again, thank you all for your time and attention, and thank you all, more importantly, for all that you do for your patients, and really providing compassionate, patient-centered care. So Ann, anything else from your end?
No, I don't think so. Just thanks so much, Tim. We really appreciate you. Yep. I'm going to start using some new words.
Thank you all.
All right. Thank you, everyone. We're going to end the meeting now. Bye-bye.